Hey guys, this is Dr. K. So today we're going to be talking about quality performance outcomes, and this is chapter 9 in your textbook if you are following along with that. So, performance outcomes are a predetermined set of goals that are met consistently when the same standards of care are given. So they basically, it's the measure of a quality or of the quality of an organization, and it can measure an organization's performance or client care outcomes depending on the measurement tool. Then we also have standards. So those can be developed and made available in multiple different ways. Public regulatory process or private voluntary processes. This may also determine licensure and accreditation. And then it's a measure, standards are a measure of consistency and uniformity and set expectations of performance. So, some examples of healthcare outcomes, quality measures. We have mortality, physiologic, clinical events, symptoms, and functional. And then so we have an example of those listed next to it. So for mortality, it would be like infant death rates. Physiologic would be blood pressure. Clinical events would be strokes, then difficulty breathing, and then walking a designated distance. You may have heard in the clinical setting the core measures or the quality measures, um, someone asking if those have been done on a patient. These are typically like our heart patients, our stroke patients, people like that we have a set guidelines and set things that we have to document, do, achieve with these patients while they're in our care. We're going to kind of talk about this a little bit further on down, but basically, Medicare and Medicaid services require that quality measures be done with certain things for funding purposes. So that's why it's such a big deal. Okay, so quality of healthcare is determined by how well a doctor, a hospital, health plan, or other providers of healthcare keep its members healthy or treats them when they're sick. So it's meeting or exceeding customers' expectations. So we always want to provide a high quality healthcare. So we want to do the right thing at the right time, right way, right person, and getting the best possible results. So quality can be measured through performance outcomes, and then those measures of quality are used for multiple different reasons. So quality overall is a concept, and the Institute of Medicine defines it as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes that are consistent with current professional knowledge. And then our measures of quality purposes can be things like the drive quality improvement, public accountability, informing consumers of their decisions, and then pay for performance. So, just a quick little backstory or back knowledge on the history of quality measures in healthcare. So, quality obviously is not a new concept. Plato was originally credited with inventing the term quality, and the modern quality movement began in the US in the late 1920s with Walter Shewhart, and he essentially provided insight into the collection, analysis, and the presentation of data in the quality discipline. It was also developed, or he also developed control charts that provided a statistical basis for separating variation. And then in the 1950s, Japan emerged as an economic power in response to the emphasis on quality. And then in 1986, Bill Smith set forth the Six Sigma set of practices, and that basically manages process variation to eliminate defects. It's since been adopted as an approach for quality improvement and innovation, and it contributed to the knowledge of quality management. So, quality management is essentially just a method for ensuring that all activities necessary in designing, developing, and implementing a product or service are effective and efficient with respect to the system and its performance. So that's essentially what quality management is. So there's several different regulatory and accrediting agencies when it comes to quality measures and quality performance. So we have the Center for Medicare and Medicaid Services, or CMS, and I kind of mentioned them just a little bit ago. We have the State Departments of Health, Joint Commission, or JACO, and the Institute for Healthcare Improvement. So, the Center for Medicare and Medicaid Services, we all know, is obviously a federal agency. Um, and they provide information for health professionals, regional governments, on how to set organizations or how to meet those standards for organizations that are set by CMS. So they have a set of rules and regulations, and those contain the minimum health and safety requirements that hospitals have to meet to participate in Medicare and Medicaid programs. So, kind of like I was saying earlier, you may hear, have you done your core measures, your quality measures? Those are all set forth by the Center for Medicare and Medicaid. And if those are not met, those are just the basic safety things for whatever the patient is there for. And if those aren't met, then the hospital CMS can come back and say, well, we're not going to reimburse you because your core measures, your quality measures weren't met. So this is known as the conditions of participation. So every healthcare organization has to meet those guidelines in order to be reimbursed for the care provided to the Medicare clients. So kind of like I just explained. Um, CMS gives deemed status to some accrediting agencies, so that certifies that the accreditation meets the standards that are set by CMS. They work in conjunction with the Hospital Quality Alliance, and then they are supported by the Agency for Healthcare Research and Quality. So the state departments, obviously we know, regulate healthcare organizations in each state. So this is going to be like your health departments and things like that. So they monitor the quality of care and have processes that facilitate public reporting of complaints regarding safety and quality. They represent from the state health department, or representatives from the state health department can conduct inspections based on a reported event, and then many collect and provide performance information about specific healthcare providers or organizations. So their big responsibility is overseeing, or they have the responsibility of overseeing to ensure the public healthcare is safe and that organizations follow the conditions outlined by CMS. So this is also part of the reason why your state departments have to report certain illnesses, outbreaks, things like that, because it's all monitored and CMS follows all of that as well. So then we have the Joint Commission. They are an independent nonprofit organization, and they are the nation's predominant standard setting and accrediting body in healthcare. So they usually come around every year or two. It kind of varies per hospital and what's up for accreditation and all that. But they evaluate an organization's compliance with quality and safety standards. So if JACO comes, we call Joint Commission JACO. If JACO comes and you fail your JACO inspection or audit, that's a big, big deal because they're the ones who give you an accreditation. And if you lose your accreditation, you lose all the things. You lose your funding, you lose CMS stuff. It's a hot mess express. So that's why when JACO comes, the hospital makes such a big deal about their presence and following the rules to a T. Okay, so next we have the Institute for Healthcare Improvement. They are also a nonprofit organization, They lead improvement of healthcare throughout the world. They work, or their work is funded primarily through fee-based program offerings and services. And they're also supported through the group of foundations, companies, and individuals. They've conducted the 5 Million Lives campaign and the Leapfrog group, which we're going to talk about now. So, the 5 Million Lives campaign was targeted for a reduction of 5 million instances of harm from December of 2006 to December of 2008. Its aim was to support the reduction of medical harm, so unintended physical injuries resulting from or contributed by medical care, including the absence of indicated medical treatments uh, that requires additional monitoring, treatment, or hospitalization, or that results in death. So, the goal of a reduction of 5 million incidents of harm in 2 years was based on an estimate that 40 to 50 incidents occur per 100 admissions, which is a total of 15 million incidents of medical harm each year in the US. So that was a really big thing, and why they wanted to implement that campaign, because 40 to 50 incidents per 100, that's 40 to 50%, which is a very staggering rate of things that happen. So that's why so many safety measures are in place, is also largely due to this campaign. We had a lot of safety things come out after this, and steps that we utilize to make sure that we're not missing core pieces in a patient's care. So the Leapfrog campaign was formed in 1998. It's a voluntary program that aimed at mobilizing employer purchasing power to alert the U.S. health industry on leaps in healthcare safety, quality, and customer value so that they will be recognized and rewarded. So it works with its employer members to encourage transparency and easy access to healthcare information, as well as providing rewards for hospitals who have a record of high quality care. So, groups of large employers came together basically to discuss how they could work together to use their ability to purchase healthcare to have an influence on its quality and affordability. All right, core measures. So, hospital core quality measure sets exist for several different things, and I've kind of mentioned a couple of these already. So, acute myocardial infarctions, MIs, heart attacks, heart failure, pneumonia, surgical care improvement projects, and then the Joint Commission has core measure sets. So, pregnancy and related conditions, and then children's asthma care. And each hospital has to submit data to CMS, or the Center for Medicaid Services, to receive a score for each of these measures. So it represents the percentage of cases in which the hospital provided the recommended care. CMS then publishes the performance data each quarter, and it allows the public and the payers to observe how a hospital is performing relative to other hospitals, and helps kind of facilitate value based purchasing, or where they want to go for their health care. So, all of the hospital core quality measures used by the Joint Commission and CMS are endorsed, are endorsed by the NQF. And the NQF is a nonprofit organization that works to improve healthcare outcomes, safety, and affordability for everybody. And then value based purchasing, I know I mentioned that in the very last little part of that slide, links Medicare payment to a value based system to improve healthcare quality, and that includes the quality of care provided in the inpatient hospital setting. So, participating hospitals are paid for care services based on the quality of care, not just the quantity of services that they provide. So, how do we improve the quality of care, you might ask? So we have to first understand how to improve performance indicators with the foundation of continuous quality improvement. So, which is CQI. So CQI is a framework for improvement that continually assesses the various aspects of care delivery and asks questions like, how are we doing? What can we do to do this better? How can we be more efficient? And how can we do this in a more timely manner? So, this should include the systematic assessment of current practices, a plan to implement improvements, and a clear goal with a vision of the desired outcome. So, there's three different things that CQI initiatives focus on. So, it's structure, process, and outcomes. So, structure includes physical space and building, human resources such as the staff, and financial and technological resources. These are usually easily observed and measured. Process focuses on activities, tasks, and workflow that achieve specific results and outcomes. And an example of this would be activities related to diagnosing and treating patients, such as med reconciliations, things like that. And then outcomes can represent a change in patient health status due to specific interventions. So, measures such as knowledge, quality of life, satisfaction with care, health behaviors, and clinical indicators are all outcomes. The IH model for improvement. So the PDSA, Plan, Do, Study, Act. So PDSA is a very, very common thing used for improvement and quality improvement in healthcare. So when I was going through my doctorate program, this was actually in my quality improvement slash project that I had to do for like my thesis at the end. It it was heavily based on the PDSA cycle. So it's a foundation for improvement initiatives in the IHI model. Consists of a series of steps that focus on goal setting, team building, planning, and testing possible improvement interventions. And it's a cyclical process and can be repeated over and over in a continual process for improvement. So basically, you set a plan, you do the plan, you study how it worked, and then you take action and make changes based off of what you have found. So next we're going to talk about the Toyota Lean model. So its primary focus was to eliminate waste in a system by applying manufacturing based approaches. So sorry. So it states that improving quality of care is accomplished by streamlining value added activities as identified by customers, eliminating non value added activities, and mapping and monitoring processes from start to finish. So the lean quality improvement projects strive to eliminate waste, so time and resources, improve the workflow, decrease delays in care, apply evidence for decision making, and empower and motivate staff to develop and sustain improvements. Improvement teams typically include a variety of stakeholders, one or two members who have little knowledge of the problem because they can serve as fresh eyes, and then a series of work meetings to assess the problem, identify areas and strategies for improvement, and make significant changes in a very short time frame. Nurses directly and profoundly affect the lives of clients and are critical to the quality of care they receive. So, you are the person who is providing basically 24/7 care. You're with the patient all day, every day. The doctor's not, therapy's not. So, your nursing performance measures are going to play a very large part in the patient's quality of care and their stay. So, standardized nurse care performance measures are a major factor in healthcare, obviously, for these reasons. We have higher client expectations. have produced a greater demand for quality. So you've probably kind of seen this in the clinic setting. Some patients, I don't want to say are, end quote, needy, but require a little bit more um, tender loving care than some other patients. So some patients do have higher expectations. Others are really chill and they don't ever ask for anything. But it's just kind of dependent, and every patient varies. So several aspects have to be addressed in the context of quality care. So we have to look at the client acuity. So how sick are they? The length of their stay, a shortage of qualified nurses, changing technology, expansion of public health services, and expansion of community health services. So typically, the less or like the less critical that they are, so say that they're there for some like pneumonia, but it's not a severe case of pneumonia. They're there for some IV antibiotics, maybe there for a couple of days, go home, discharge on PO antibiotics, and then maybe follow up with their PCP, may even qualify for home health. So those kind of things are like the public health services and community health services we do look at when we're discharging patients to see what they qualify for, if they can get home health. Here in Jonesboro, we have the Jonesboro Church Health Center. It's free to anybody who does not have, or I don't want to say free. Anybody who does not have health insurance can go there and they pay for cost. Like that is it. They pay the cost that the clinic pays, um, and they're able to receive health care and be followed by a physician and a team of providers. So the National Database for Nursing Quality Indicators. The ANA, or the American Nurses Association, launched the Safety and Quality Initiative to explore and identify the empirical linkages between nursing care and patient outcomes in 1998. So, nursing sensitive indicators from this database, national database, reflect the structure, the process, and the outcomes of nursing care. So, the structure of nursing care is indicated by supply of nursing staff, the skill level of the nursing staff, and the education and certification of the nursing staff. Process indicators measure aspects of nursing care such as assessment, intervention, and job satisfaction. And then our client outcomes are determined to be nursing sensitive, um, and are those that improve if there is a greater quantity or quality of nursing care. So, pressure ulcers, falls, IV infiltrations, things like that. And some client outcomes are not considered nursing sensitive because they are related to other aspects of institutional care. So, like medical decisions that are made and institutional policies would fall in that category. So now we're going to talk about magnet recognition. So magnet status is a measure of nursing performance, and the designation is awarded by the American Nursing Credentialing Center. Their healthcare organization, or the healthcare organization that they're accrediting with the magnet status, must demonstrate an environment of excellence for nursing practice and client care. So, research shows that magnet hospitals have better client outcomes, a higher level of client satisfaction, as well as a higher level of nurse satisfaction. So, in order to achieve this status, a team of professionals with experience in quality indicators, nursing administration, and nursing care have to evaluate a hospital's nursing services, the clinical outcomes, and the client care delivery systems. And then there's 14 forces of magnetism, and these must be achieved by an organization prior to becoming a designated magnet hospital. So the ones that are closest to us, we don't have any magnet hospitals here in Jonesboro. they're going to be like your probably more like your big research institutions like Le Bonheur and Arkansas Children's are both magnet. I can't remember off the top of my head if UAMS is or not. I think that they are. So, one big thing with magnet status hospitals is you have to have your BSN. So they want you to have your bachelor's degree if you were working there as a registered nurse. Sometimes they will hire you on if you have your associates, but they give you a time frame that you have to have your BSN completed. So, like children's, I think I was in like eighth or ninth grade, and my mom worked at children's at the time. She still does. But Children's went magnet and she only had her associates because she went to nursing school in like the 90s, and BSNs just weren't like a huge thing back then. A lot of people went to community colleges, and so when they went magnet they gave her like, I can't remember if it was like 3 or 5 years to go back and get her BSN, which BSNs are a year-long process and it's all online. There's no clinical or anything like that. So sometimes you will run into hospitals that who are magnet and they'll give you um, so many years to go back and get your BSN if they hire you on. And some places also do offer reimbursement once you've graduated up to a certain percentage. I think they reimbursed her like 50% or so. I don't know. It was a pretty decent amount. Anyway, I say all that to say that's one of the biggest things with magnet hospitals is you do have to have your BSN. So cost and performance. Pay for performance is an important movement in healthcare insurance. Providers under the arrangement are awarded for meeting pre established targets for delivery of healthcare services. And then, honestly, we really need more research on pay for performance programs. The design of these programs and ongoing efforts to evaluate their effectiveness should eventually provide the basis for understanding how best to use financial and other incentives to leverage that continuous improvement for safety and quality. And then quality of care in vulnerable populations. So, we obviously know that we have a wide range of disparities in education and income levels are associated with vulnerable populations when they're accessing health care. So, the ethnic composition of the United States creates a demand for health care, for a healthcare system that is more responsive to minorities and needs of the vulnerable. So 28.2% of the population falls into this, and it's expected by 2025 this year that that's actually going to increase to 37%. So vulnerable populations include the uninsured, the working poor who do not receive adequate health benefits, underinsured, and limited access to preventative care. So the growing demand for healthcare providers is high for those who speak English and other languages because they can help bridge that gap in healthcare. Whereas maybe people don't have access or they don't seek healthcare because there's a language barrier or they just don't understand. So if you're bilingual, that is a very good thing. And a lot of hospitals will give you like extra pay if you are bilingual because it is super helpful in helping to take care of patients, and you don't have to try to hunt down the translator phone or a physician or someone who can speak fluently in that patient's language. I know Dr. Arroyo at St. Bernard's, he's one of the cardiologists. He is fluent in Spanish. And I always loved whenever I had his patients because like he never had to ask for anything because if they were Spanish speaking, and we do have a very large Spanish speaking population here in Arkansas. If they were Spanish speaking, he just like he rattled off whatever he needed to, and they were able to understand, and it was like, oh, beautiful. And then he would come out and say, hey, this is what we talked about. And I'm like, okay, great. So it does definitely help. when you are bilingual, you can make sure that what you're saying to the patient is actually what they're needing to hear. Sometimes, obviously, when we're having to use translator phones or someone translating, we can't really understand or know for sure what they're saying. So sometimes there may be some confusion and things like that too. Many Americans live in poverty or living in poverty are victims of also social and environmental harms. So those can include drug addictions, um, AIDS, crime, and chronic illnesses. And then infants born from mothers with substance disorders can also suffer from addiction, low birth weight, and even mental and physical problems. So those are also issues that are related to vulnerable populations. So, the need for healthcare services for vulnerable populations is ultimately really strongly tied to the poor economic conditions of the communities in which they reside. So, we're really trying to bridge that gap, and there's been a lot more resources come out recently in probably the past 8 to 10 years, I feel like, um, trying to help bridge that gap in healthcare with the vulnerable populations. So, all right, that is all I have for you guys today. If you have any questions, just let me know. Thanks.